The broadcast is now starting. All attendees are in listen-only mode.
Good morning, everyone. Welcome to another SWORB region webinar presented by myself, Stephanie Romano, a regional paramedic educator, and Dr. Samir Mao, a PGY4 and our EMS fellow. Today we have a presentation on out-of-hospital termination of resuscitation, and it's triggered mainly by the new medical directives and a medical TOR. So with our objectives today, we plan to explain the differences between the medical and traumatic arrests in general. We plan to summarize evidence supporting out-of-hospital termination of resuscitation, and we'll take you through a series of research to show you that our medical TOR is quite valid. We're going to talk about the plan of action between PCPs and ACPs on scene of a medical TOR. And we'll talk about any key information to provide base hospital physician when patching for a TOR. So we'll walk you through a TOR and maybe from both the perspectives of the paramedics and the physicians what we'd be looking for. And then we'll also discuss the steps paramedics can take in terms of death notification, because this is something that will be new to many medics.
All right, and those are the objectives. Here's how we actually plan on completing all of those. We're going to start the talk with a case presentation of an arrest patient, and then move on to what the difference is between a field pronouncement and a TOR. They're similar, but not quite the same thing. Next, we'll talk about the types of arrests there are and what the differences are between traumatic and medical arrests, and why your medical directives are set up the way that they are to deal with those situations differently. Next, I'll be going through some research for out-of-hospital termination of resuscitation, and I'll try not to bog everyone down with too many numbers there, but I believe it's important just to see where these medical directives for the termination of resuscitation actually came from. Next, we'll be handing it back to Steph, and she'll take us through the current medical and TOR directives, as well as the scene plan of action that we talked about just now. We're going to finish off the presentation by talking about a special circumstance, which is death in a public place, and we know that's brought some anxiety and a lot of questions for many of the medics out there, so hopefully we can help lay some of the myths to rest. And then lastly, we'll finish off the presentation going through some steps of death notification, as for many of you this may be a new thing.
Okay, and so just before we get into the actual data of our presentation, if you're new to webinar, you do have the ability to talk to us or to provide questions through the chat box. So feel free to type any questions in the chat box throughout the presentation. We can take a couple seconds and answer those as we discuss our different slides. We'll then open up the presentation at the end to any live questions if you happen to have a microphone with you. Otherwise, we can answer more chat questions at that point too.
And we absolutely encourage you guys to ask questions as they come up. We love being interrupted, so hopefully we can deal with things as they come up.
Okay, so into our presentation then. We're going to take you to a case presentation or a case study. And this is an actual call that happened just recently in SWORB region. So imagine you're a PCP crew. Bell goes off and you are called code 4 for a 66-year-old male patient, unresponsive. So you arrive on scene, and the patient's son is actually performing CPR, said that the patient had had dinner, and about 30 minutes later was in the bathroom vomiting. And so the patient's son went in to check on him, found him unresponsive, and initiated CPR. So when the crew arrived, CPR was in progress, went through their medical cardiac arrest medical directive, had 3 no shocks indicated, and the patient was in asystole. And they did patch for a TOR, and it was successful. So if we take a second and rewind back to last year with our old medical directives, if this call had occurred at that point, the PCP crew would have actually completed 4 analyses and then transported that patient to the hospital for ALS care there.
Oh my God!
So part of our presentation today is to talk about why the medical TOR is here, why we're practicing it, why some medical patients are futile, and some of the other sort of implications of transporting patients that are futile. So one of those implications is potential danger to paramedics, and of course the public.
You hit a 7 series too. Oh my God.
And so of course this is obviously another possibility. Again, safety to paramedics and the public is definitely something that we need to keep in mind.
All right, thanks, Steph. So next we'll be talking about different types of arrests. And firstly, we're going to start off with traumatic cardiac arrest. And this is a very different entity than the medical cardiac arrest, and that's why the medical directives are set up in the way that they are. Quite often when patients deteriorate from a trauma, it's due to a very significant injury. For example, they can have an arrest secondary to hypoxia, for example, from a large pneumothorax, maybe a tracheobronchial tree injury, a large flail chest with pulmonary contusions. Secondly, patients can arrest from injury to vital structures, this being the heart, the lungs, the great vessels, the pulmonary arteries, the aorta. As well, patients can arrest from severe head injury, and this is brainstem dysfunction, respiratory collapse. And the most common cause of shock in traumatic patients is hypovolemia. And like I said, most common cause of shock, and it's due to some uncontrolled bleeding somewhere that you can't potentially immediately compress. Really, the focus of EMS personnel should be to safely extricate and attempt to stabilize these patients. In the new medical directives, there's been a shift from endotracheal intubation to greater use of supraglottic airways as they provide good airway control and really help minimize the scene time. Patients who have a traumatic arrest are in need of definitive care, which most often in these patients is surgical. They need to go to the operating room, have big bleeding vessels tied off or whatnot. So we really want to minimize all pre-hospital interventions that will delay patient transport to receive that definitive care. If pulseless arrest develops in a traumatic arrest, the survival rates are extremely poor unless there is an immediately reversible cause that's found, for example, maybe decompressing a tension pneumothorax. Most often, PEA in this situation will be secondary to maybe hypovolemia, tamponade, or hypothermia. Remember our H's and our T's for our PEA arrests. For the bradyus asystolic arrests, it's often a sign of severe hypovolemia, severe hypoxia, or end-stage cardiorespiratory failure. VF and VT is treated in these patients the same as in medical arrests. So to conclude the traumatic arrest, the studies have demonstrated that those patients who do survive traumatic arrests have very prompt transport times, have treatable penetrating injuries, and typically tend to be younger. Next, moving on to medical cardiac arrests, these are a little bit different in that the majority of people who suffer an out-of-hospital cardiac arrest from a medical cause tend to be older and have many comorbidities. By far, the most common cause of medical cardiac arrest is cardiac disease, upwards of 60 or 70%. And this can be from coronary artery disease and an MI, maybe a cardiomyopathy from long-term hypertension, or valvular problems. The next big group of non-cardiac causes, and this is 30 to 40% of people, are your non-traumatic bleeds, toxicologic overdoses, drowning, and pulmonary emboli. And these will differ a little bit depending on the patient population that you study. But medical cardiac arrest, if you think about it, just to simplify it as much as possible, medical cardiac arrest can be thought of as a pump problem. More underlying complex physiology, and these patients are usually more unwell. You know, once the heart muscle is dead, it's dead. A traumatic arrest you can think of as having to plug a pipe that's burst open, and so you're filling them with fluid, trying to temporize them. Their pump is still working great, but then you need to transport to hospital. So next, moving on to termination of resuscitation. And like I said earlier, out-of-hospital cardiac arrest has a very low survival rate to hospital discharge. Even the best studies with the fastest response time show maybe survival rates up to 30%, but most broad studies show survival rates somewhere in between 5 and 10% of people. We know that transporting all patients results in the inappropriate utilization of really valuable resources. And this is the part that some medics have had trouble with, and it's something that I think most medical students and residents go through as well, because there's this thought that shouldn't we be doing everything for everybody? And I definitely struggled with this myself going through my training. And really at the end of the day, not much of what we do has been, the advanced care has been shown to make a difference in these patient outcomes. I mean, you can only really do CPR on someone who's not breathing, who doesn't have a pulse, and who's dead. And typically, dead is generally an irreversible condition. So what we're trying to do here is balance providing each patient the opportunity to achieve ROSC and a meaningful survival against some of the unnecessary allocation of valuable EMS and hospital resources, and of course the dangers of high-speed transports. Clinical decision rules, like the ones I'll talk about later, are meant to help aid us in identifying this group of people who really cannot be saved by any advanced methods. So just for kicks last night while I was putting this presentation together, I decided to Google ambulance crash in the news and just see what came up. And I guess it's a bad week to drive a rig. This gentleman here actually died the night before last after his car was T-boned in New Orleans by an ambulance going lights and sirens to the hospital. Left a family behind. Same night, that was in New Orleans. This one here is in England. This unfortunate driver here went through a bus stop and almost through a coffee shop. No one was killed in this incident, but a few people went to hospital. And I mean, these are just a couple small examples, quick examples of some of the dangers of transport. It is very real. And just quickly, I mean, is the cost associated with futile medical care. These arrested patients are not cheap to take care of, especially in hospital. They require lots of expensive drugs, tubes, ICU time. So really what we're trying to do here is determine patients for whom this futile care won't take us anywhere, that's futile, and thus maybe it'd be better off for the patients, for the paramedics, for everyone involved to let those people go in with some dignity.
Okay, so keeping that in mind, this by no means is an encouragement for a no service on any other type of patient. This is specifically for medical cardiac arrest patients, and keeping in mind the resources being used. So if we look back, or even look forward, and to compare the ACP versus PCP medical TOR field pronouncement, an ACP can patch following the third analysis of a medical cardiac arrest for further direction from that base hospital physician. And that further direction could be more ALS care, more medication, it could be a field pronouncement, it could be direction to transport. Let's turn back to last year and look at the primary care paramedic, what they would actually do in the case of a cardiac arrest. And really there was no chance. It was either call for ACP backup if it was available in your service or transport to the emerge. And transporting to the emerge, as Samir has said, we are introducing danger to the crew and public, using resources like the PCP crew, emerge staff, CAC resources, and something else that we haven't yet talked about is providing false hope to the family, which may be alleviated in some cases with the new medical TOR, which in that case we can patch as PCPs following the third analysis if certain criteria are met, and we'll talk about that criteria shortly.
Okay, so the next part of the presentation, I'm going to take over and go through some of the research behind our current medical TOR. And I'm going to start off by talking about clinical decision rules really quickly and exactly what they are. The medical TOR is an example of a clinical decision rule, and these are tools that help physicians quantify the contributions that various components of a patient's history, physical exam, and lab results make help towards pointing us towards a diagnosis or giving us a prognosis of some sort. There's lots of them out there you've probably heard of, the Ottawa ankle rules for who needs x-rays, the Canadian C-spine rules, the CT head rules. All of these are examples of clinical decision rules that help us in a specific patient population. They're most likely to be useful in situations where the decision making is really complex or the stakes are high, and there's opportunities to achieve cost savings without compromising patient care. There's three general steps to making a decision rule. You can see those on your slide. First is the derivation. That's really where you look at a population that has disease, come up with some factors that seem to be related to it, and some fancy statistics can help determine which ones are really important. Once you have that list of factors, these rules go to validation studies, and these are done first in small groups of patients and then in larger, broad groups of patients in multiple centers with multiple comorbidities to see if the accuracy of that rule still holds up. The last process of a clinical decision rule is usually an impact analysis, and that's to see at the end of the day if we were changing anyone's behavior by using the rule, if we were saving any money or having better patient outcomes. So now to review some of the evidence for the pre-hospital BLS termination of resuscitation. So I'll go through a bunch of studies now. This first one was done in the New England, published in the New England Journal of Medicine, in 2006. And this was a prospective study, so looking at following patients from time 0 forward. And this was all arrest patients in 24 EMS systems in Ontario. They had a total of 1,240 patients who enrolled, and these were arrested patients, and every single one of these patients had this BLS TOR rule applied to them. All patients still got transported, but these patients had this rule applied to them, and the researchers wanted to follow them through hospital and see how their outcomes were. So what were the researchers looking for? They're looking for who was pronounced in the ED, who died after admission, who made it to discharge, and were they mentally okay at the end of it? And did they suffer any hypoxic injuries? They excluded patients who had non-cardiac causes of arrest. And down on this slide you can see the results. In total, out of the 1,240, the BLS TOR rule in this, which is the same as the medical directive that you currently have, 776 patients would have received a TOR. And in this study, only 3 of those patients survived, 3 out of the 776, to a good neurological outcome. So the predictive value for death in this study for this rule was 99.5%. And if this rule was followed, it would have dropped transport rates by 62.5%. So just one example. So again, only 0.5% of people who were predicted not to survive actually did survive. The same BLS TOR rule was then tested in a different patient population, and here this study published in the Annals of Emergency Medicine in 2006 looked at all patients at a few centers in Ontario, at 21 centers, over 13,000 patients, arrested patients, and this was retrospectively in their database. They went back and compared 3 different BLS TOR guidelines, which I'll put up here on the next slide. And they tested all three of these guidelines in their retrospective data, so data that's already been collected, to see how they performed. So the BLS TOR rule was no ROSC, no shocks, and unwitnessed arrest. There was the Peachy rule. This is another rule that's been published in previous research, which said you should TOR in cases of initial asystole, EMS response greater than 8 minutes. And then lastly, there was the Marsden rule, and this is where patients have no shockable rhythm, no ROSC, no CPR for 15 minutes, or they're asystolic. So what did they find here? They were looking for some of the same outcomes as who is surviving the hospital discharge and how's their level of function. They excluded non-cardiac arrests again. And here are their results here. Excellent numbers, as you can see. Over 14,000 patients, all BLS care. Every patient in the study got BLS care. In total, 4.7% of people survived the hospital discharge in their entire study. A TOR was recommended in total in 5 patients out of the 636 who survived, so that's 0.7% of people. All 3 rules, as you can see, had very high predictive values for death, 100%, 99.9%, 100%. And the transport rate, the drops in transport rates were great, especially for the BLS TOR rule, which is 50.5% in transport rates had it been followed. So next, like I said, we need to use these rules in different populations with different providers to see if they maintain their accuracy. So here's a study of just over 2,200 patients in Singapore. Again, all patients were arrested, received BLS care, and this was a retrospective study looking in their database of already collected data, and they used the same 3 rules. Again, just seeing who survives to discharge, and they excluded people who are obviously dead. And here's how these rules performed. These same rules went from Ontario to Singapore, and here's how they performed here. The BLS TOR rule, 99.6% negative predictive value for survival, and it's in their study would have been 68.7% drop in transport rate. The Petrie and the Marsden rules below you can see had negative predictive values that were again very close to 100%, and their drop in transport rates were 30 and 63% respectively. So where are we at right now with the BLS rule? Well, like I said before, and there's many steps in the derivation of a clinical decision rule. So right now, the BLS rule meets level 2 criteria, and that's really just a fancy way of saying that this rule has been validated in either one really large prospective study or in really small studies around the globe in different patient populations, and maintains its accuracy. So really, this rule is now ready for prime time. That's the BLS TOR rule. So again, all these studies were going through arrested patients who received primarily BLS care, and that hopefully explains a little, reflects why the directives for the BLS TOR are the way they are. There's also research pending for ALS TOR rules, and I'll go through some of those studies right now. This first one here, I'll present the rules in the next slide, but this was a very large prospective study of, I think they used about 19 EMS systems in this study, and the patients in this study had a mix of both BLS and ALS care. So they used previously derived BLS and ALS TOR rules and just wanted to see how they performed in this patient population that is now receiving extra levels of care. So here are the two rules. Once again, the BLS TOR rule, no ROSC, no shocks, and unwitnessed. And here's an ALS TOR rule that had been derived earlier, not yet validated. And this TOR rule says that you should TOR if there's no ROSC, no AED or shock before transport, unwitnessed by EMS or bystanders, or no bystander CPR. So this is just taking some extra things into consideration. Outcomes, they're looking for the same thing: who survives the hospital, discharge, and how are they performing, and they included traumatic arrests. So what did they find here? Preliminary results from their retrospective data showed the BLS TOR rule performed equally as well in this population, almost 100% positive predictive value for death, and a 47.1 drop in transport rate. Their overall survival rate was only 7.1%, 392 people. And out of the 2,500 people that the BLS TOR rule would have TOR'd, only 5 of those 2,500, that's 0.2%, survived to hospital discharge. With the ALS TOR rule, there were 1,190 patients out of the 5,500 that the rule predicted would die. And in that rule, none of the patients survived to hospital discharge. So you can see that the transport rate, the drop in transport rate wasn't as great, but the corollary is that we didn't miss any people who ended up surviving to hospital. So both these rules performed well in identifying patients without a hospital cardiac arrest who have little chance of survival. Another study here, this is a retrospective study, done in just over 2,100 patients in Arizona. And this is where they evaluated the BLS TOR rule strictly in patients who received ALS care. So now we're taking the BLS rule and trying to apply it to multiple different settings and seeing how it works. They tested this in 30 EMS systems in Arizona. Again, the outcomes were very similar to the other studies: who survives to discharge and how do they do mentally. And their results here are at the bottom. In this group of patients, in total 1,160, in total just over 2,500, 1,160 patients were predicted by this rule to have no chance at survival. Positive predictive value, almost 100%, 99.9% of a positive predictive value, and almost a 70% chance in drop in transport rates. Out of the patients here that the rule predicted patients would TOR, only 2 survived. So again, very small number of patients are actually surviving who are predicted not to. Last study here, this one was done more locally in Ontario. Hopefully I haven't lost everyone yet. I swear I'm almost at the end of all this research. But this was a prospective study, 2,500 patients done in Ontario using a BLS and an ALS TOR rule to see how they performed. Same outcomes as usual. And here's how they performed in our combined patient population who received BLS and ALS care. Both the rules had positive predictive values of 100%, so everyone who the rule said would not survive did not survive. And the BLS TOR rule seemed to drop transport rates much more, 54.4% versus 31%. So sorry about all the research there. What does that actually tell us at the end of the day? So an out-of-hospital cardiac arrest, patients who receive only inpatients who receive only BLS care. The BLS TOR rule has been prospectively validated in a very rigorous fashion, and it's ready for prime time. It's ready. It's warranted for widespread use. And that's why your medical directives, the new 2011 versions, reflect those changes. With respect to patients receiving mixed care or strictly ALS care, neither TOR rules have been quite studied enough. The initial findings were very robust, and they suggest that this BLS TOR rule should be okay to apply in these patients, but the level of evidence in the mixed population just quite isn't as high yet as the BLS population. So that's why there's still the difference in the medical cardiac arrests for PCPs versus ACPs. So I hope I was able to clear up a little bit there and not confuse everyone even more.
So while Samir was presenting that information, we actually got a comment from one of the medics through our chat box. And it surrounds the concept that some medics just aren't comfortable calling for a medical TOR. And we'll get into the details of the medical TOR shortly. But the evidence that Samir has just presented is showing that we have a medical TOR for a reason. And that the mandatory patch point is there, again, for a reason. I mean, we're practicing evidence-based medicine. And the results from those studies, I mean, we saw 100% several times, in those studies. So, I mean, of course, there are unusual circumstances which we will discuss, and we'll provide a little bit of guidance for you. But of course, our goal here again is to provide some support to the medics during this transition. Our plan is not to leave you blind and with a strict protocol in front of you and just say simply follow it. We're here to provide some guidance and support and make sure that you do become comfortable and give you tools so that you do feel more comfortable in those situations. So we'll get into the actual medical TOR. And SWORB region has done something to make this a little bit more streamlined and simplified. So we're talking about the PCP medical TOR here that applies to all medical VSAs. And the way that I've taught this in my research is to think about very generally that patients can die of three things. Now think very generally here. Of cardiac origin, of asphyxial origin, and of traumatic origin. Now, for the purposes of simplification, we've decided to combine those cardiac deaths and asphyxial deaths into medical deaths, which means that your hangings, your drownings, and your electrocutions are combined and do qualify for a medical TOR. Now, if you're calling for a medical TOR in one of these unusual circumstances, so the hanging, drownings, and electrocutions, based on the big picture and based on all of the considerations, the base hospital physician may be more likely to ask you to transport a patient who has died of asphyxial origin. But again, they're going to take everything into consideration and look at the big picture. So if you have a patient who is at least 18 years of age, has had no ROSC throughout your call, has had no shock delivered by you or other EMS personnel, and provided the arrest was unwitnessed, there is a provincial mandatory patch point following the third analysis. Now again, as I discussed, we're going to get into maybe one of the most hot topics, which is your medical TOR in a public place. But do keep in mind that that patch point is mandatory following your third analysis. And
if I can jump in really quickly, this, like I just went through all this research, meeting these criteria, these patients have a 99.9% chance of not surviving. So this isn't something that we've just created out of the blue. There is very good evidence behind this, and we are trying to prevent some of the pitfalls of high-speed transports that I spoke about earlier.
Okay, so let's talk about that hot topic then. So medical TORs in a public place, and I know that this has come up quite frequently in research, and a lot of medics just aren't comfortable with the idea. So keeping in mind that this is an unusual circumstance, and unusual circumstances are unusual, they're rare. So in this case, we can really just ask you to use your best judgment in conjunction with your directives, okay? So you have two options here. You can call for the medical TOR and discuss the exact situation with the base hospital physician and discuss what your options are at that point. Keep in mind that the base hospital physician is, of course, understanding and will try to do what's best for both you and the patient. Your other option, of course, is to move the patient to the truck and call for your TOR there. of course, services aren't necessarily going to want that, but in terms of the medical tour in an unusual circumstance, for example, in a public place, you do have two options, and of course your safety comes first.
And Adam and I have been, we've put out some webinars for all the emerge physicians working in the SWORB region as well. So this isn't some, well, as long as they've watched it anyway, this shouldn't be something that's new to them. So if you are calling for, if you're a PCP medic calling for a medical tour, this isn't something that's going to surprise or shock them. And absolutely, don't be shy.
Okay, so something else that's been a little bit of a hot topic is how PCPs and ACPs can work on the scene of a medical tour together. And the goal here is to create some sort of teamwork framework so that you can, of course, work together. So the guidelines, the theories here, are that if a PCP crew is first on scene of a medical cardiac arrest, continue to go through your protocol. If the ACP crew shows up and you have not yet made a patch attempt for a medical tour, then the ACP crew at the time will take over the call. If the ACP crew happens to show up and you're on the phone with the base hospital physician or even dialing, continue that call. So the PCPs will continue the call to the base hospital physicians and provide the same information that you would have whether the ACP was there or not. The only other piece of information that you would provide is that the ACPs had just shown up and are probably starting care. If the PCPs are granted a medical tour by the base hospital physician, go ahead and pass that information along to all of the paramedics on scene, and that will be respected by both PCPs and ACPs on scene. So hopefully that's clear. So again, if the PCPs are calling for the medical tour, the ACPs are to respect that, and once the medical tour is granted, we're hands off. Otherwise, if the ACP crew shows up on scene, and the PCP crew has not yet attempted the patch, then they will go ahead and take over the call. All right, so let's move on to the trauma tour guideline. Now, big changes from last year's trauma tours in that we've now combined the two blunt and penetrating traumas into one. Much more streamlined, much more clear. And we'll take you through it right now. So if we have a VSA due to severe blunt or penetrating trauma, so imagine there's trauma that you've suspected has caused this patient to become VSA. So the patient has to be at least 16 years of age, and you're going to continue CPR until the pads are applied. So remember, there's no 2 minutes of upfront CPR in these patients. So you're starting CPR until your pads are applied. Remember, penetrating trauma in the old directive, you were to use electrodes only. In this case now, all traumatic VSA patients will have defib pads applied. So as soon as those pads are ready, you're going to analyze that rhythm, analyze or interpret the rhythm. If you have a shock advised or the patient's in VTAC or VFib, we're obviously going to deliver that shock and then immediately transport, keeping in mind your packaging, of course. If, however, you were given a no shock indicated or the patient is in asystole or a PEA, we go down two different pathways here. So if the patient's in asystole, at that point we can immediately call the base hospital for a TOR. If the patient's in a PEA, so again the heart rate is greater than 0, now we have to look at our transport time. Now in the old directives that included our packaging time. So now this transport time is drive time only. So if that drive time is greater than 30 minutes, you're going to patch for your TOR. If the transport time is less than 30 minutes, so if you think you can get to the hospital in less than 30 minutes, you're going to transport. So keeping in mind that the old blunt and penetrating traumas that were separate have now been combined for simplification, it seems to be at least simple to me.
Yeah, the body of literature isn't as great for trauma tours. This isn't quite at the level of a clinical decision rule like our BLS medical tour is. From talking with Mike and from him relating the feelings of the medical council, the trauma tour was combined in these new directives mainly just for simplification. And the transport times that you see here, if someone's in PEA with a traumatic arrest in the hospitals, the trauma center is over 30 minutes away. I mean, this is someone who has a dismal chance of survival because often arrests in a traumatic situation are from some sort of devastating injury like a dissected aorta, for example. So that's why the transport time is a bit different there.
So keeping in mind, if we look back to the medical TOR, that patient had to have had an unwitnessed cardiac arrest. Same thing goes for your trauma TOR, so make sure that that patient has not had a witnessed arrest in front of you. So again, it has to be an unwitnessed arrest. So something that's new to many PCPs is the patch point for these medical TORs. So what we've done is included a patch sheet, sort of guideline reminder in your books, which you'll be getting soon. So it looks something like this. So when you call in for your patch, and we'll give sort of the paramedic and physician perspective here. So when you call in for your patch, I strongly recommend that you pull out that book and actually use it as a guideline. So you're going to call in through CAC on a taped line, provide your service and location, your name, your OASIS number, and your level, so whether you're PCP or ACP. Provide your run number, and then get down into the patient information, so the patient age and gender. And then tell the base hospital physician what you're calling for. So tell them that you're calling either for a medical or trauma termination of resuscitation. Then you're going to provide your incident history or your mechanism of injury. So let's say it's a trauma TOR. Provide significant details. So you want to share that your patient has significant head trauma or significant chest trauma. You really need to paint the picture for the physician on the other line. And then reiterate the guidelines for either your medical or your trauma TOR. So if you have a medical TOR, if that's what you're calling for, then make sure to reiterate that your patient is at least 18 years old with no palpable pulses, the arrest was unwitnessed, you've had no ROSC, and no shocks delivered. Likewise, if it was a trauma TOR that you were calling for, reiterate that your patient is at least 16 with no palpable pulses, there's no defibrillation delivered, and then your patient is either asystolic or in a PEA, and that your transport time is greater than 30 minutes. And then in terms of your own paperwork, you're going to want to grab the base hospital physician's name, the time of death if your TOR was granted, and the patch sheet number if you can remember.
Yeah, I agree with everything Steph said there. One small point that has come up before I received a patch, I think it was last month or so, where the medics had arrived to the scene of a patient who was in a severe MVC, looked obviously dead while they were still in the car anyway, but the extrication time was going to be 45, 50 minutes, so they had called in early to see if they could receive a trauma TOR without full assessment. And in this situation, if you have someone who looks obviously dead, what we'd recommend there is just quickly throw the pads on just to confirm that the patient's asystolic, and then call in, and you'll have no issues receiving a trauma TOR after that point. Just we can't proceed with a trauma TOR if we don't meet each of these criteria.
And keep in mind too, if you have an unusual circumstance in terms of a TOR, you can always call the base hospital physician for guidance or advice. Make sure in that case that you're not calling for a TOR, you're simply calling for advice or guidance. And be prepared to answer specific questions like what rhythm is the patient in, how long will it take to extricate, that sort of thing. So be prepared when you do make that call, and make sure that you're painting an appropriate picture for the physician. If the physician can't picture or see the call that you're on, it's difficult for them to give you sort of an answer.
All right, so I think right there we covered all our TORs, so hopefully we answered a bunch of questions for you. I'm sure we created a lot too, so please feel free to send those in. To finish off the presentation, we're going to do a little quick thing on death notification, as this is probably something new to a lot of you. We'll go through really just some key points that we can come up with. I mean, I have my own style that I've developed while going through my residency, and I'm sure Steph will jump in with lots of special little pearls in the kind of different circumstances that you guys face. So in general, death notification is one of those things that, shockingly enough, medics and emergency physicians deal with a lot. That's not the shocking part, but our actual training in how to give a death notification, I mean, I can't remember the last time I had a formal session on this. We go through ACLS code after code, memorizing our protocols inside out and backwards, but 95% of the time these codes aren't working, and we have to tell the family about a death, and really we just don't have the same level of training in that very large part of running a code. In general, everyone I talk to has a bit of a different style in delivering death notification, but there are certain core elements that we all share. and hopefully that's what we can take across to you today. So, firstly, going through the setup. And again, this is going to be a little bit different depending on what kind of situation you're in, especially if the family, in your case, has been watching your entire resuscitation in the living room. This is more so when the family hasn't been present or you're telling them after the fact. So, I mean, death notification, if you think about it, you're about to enter a room of people you have never met, you don't know their names, you don't know anything about them, and you're about to tell them the worst possible news that they could possibly get that day. You don't know what the family dynamics are like, who you should even talk to in the room, and you have a very quick window of opportunity to establish rapport before you deliver this horrible news. You know, again, like I said, there really isn't a right way to do it, but there definitely are some wrong ways, and we'll go through those in a second. Just basics that I like to do when going through a death notification is I treat this like any other procedure that I'm doing in the emerge, whether it's a central line, a lumbar puncture. This is going to take me 5 to 10 minutes, and I am completely unavailable during this time. I don't have my phone on. I don't have my pager with me. Walk in. You don't want to have soiled clothing. I mean, it's a bit harder for you guys in your situation. But put your jacket on maybe. I would never walk into, with scrubs covered with blood to tell a family about the death of their loved one. Learn the patient's name, please. Absolutely. This is one of the most important things you can do. Address them by their first name, Mr. or Mrs. It means a lot more to the family. Walk into the room, shake hands with everybody in the room, introduce yourself to everybody in the room, and get everyone sitting. This is definitely a good idea, and you want to be sitting yourself. At least this is what I believe, and bring yourself to the eye level of the patient. You don't want to be looking over top of them at all.
So in terms of the paramedics telling family members of the death of a family member, as much as we can respect the physician's way of doing it, our scenarios or our environments are fairly different, and there's some things that we have to take into account. There's also some things that we have in common with how it's done in the emerge. So focusing on the closest family members, often we can tell on scene who's most involved, who wants to stay in the room, who's maybe starting to interfere with how we're treating our patients, and maybe focus on those family members first. You want to deliver the news as soon as possible, so don't belabor the issue. I mean, if you need a second to compose yourself, that's fine, but don't leave the family members waiting in another room. Try to get that information to them as soon as possible.
It's just torture otherwise, like to deliver the news.
Yeah. Make sure that you tell the family that there's nothing they could have done. I've had a lot of medics say there was no pain, if that's appropriate. And if you do have any family members that are coming in after the fact, try your recap method. So maybe ask the family what they know so far, and then sort of keep them up to speed.
And that's what I use in the emerge. I use the recap method personally. I find it when family members haven't been immediately witness to the resuscitation, I ask them what they know, what happened to the patient earlier this morning, were they with you, and I let them tell their story, and this is an opportunity for me to establish a little bit of rapport as their family members will tell me about the events leading up to the arrest, and then once their story stops, I'll pick it up, and again, once I start talking, within 30 to 60 seconds, you need to deliver the news of death.
So in terms of how the call is running, it's really going to depend on the situation in terms of how EMS is running the call. Some family members are okay to stay in the room and watch what you're doing. Some family members would rather be in a living room or in a hallway waiting with police or maybe a firefighter. Some will try to interfere, so obviously your safety and what you can do for that patient comes first. But if the family can be involved at all, I would recommend that they remain involved. Try to keep them aware of what's going on throughout the call. Maybe prime them that you're going to be calling a physician in emerge at a certain point to ask for further advice, just so that they're aware that something is coming. So in your language to the family, make sure that you're direct. Do not be ambiguous. Use words that are definitive. So use your husband or whoever the name is has died, they are dead. Use the word passed away. Don't use words that leave room for interpretation. Do not use any cliche terminology, and it's perfectly fine for you to say that you're sorry. You probably are sorry that it's turned out the way that it has, and there's nothing wrong with saying that.
Absolutely, yeah. Just be authentic. Sorry is absolutely okay, and can't stress enough. Be clear with your language. Dead, died, death. There is a way to say it. You know, I'm very sorry. I have some horrible news, but your loved one has just died. But it's very important. Often people are in a state of shock and are never really as prepared as they say they're going to be for a family member's death. So it's important that you penetrate into their mind that, okay, no, this person has died.
And just be aware that, I mean, this is new to some regions of SWORP for PCPs. There are other regions of SWORP that have had this for PCPs for a number of years. But for those of you that it's new for, it's going to be a challenge to get that right terminology out. And I've had some people recommend saying, you know, we've done everything that would have been done in the emerge, yet as a PCP it may not appear that way. There might not be a tube in, there might not be a line in. It might appear that, you know, 6 minutes into your scenario that you're calling for a medical TOR, and it can look to the family as if you haven't really done much. So your delivery and the terminology and the words that you use and how comforting you are to that family is really going to count.
Absolutely. And then after you do deliver the news, right away there's invariably going to be a period of silence, and the biggest piece of advice I can give you here is just be quiet, just shut up, just be there. Be there for the family, and the family will always break the silence after some small length of time. It might seem very long to you sitting there in a new or uncomfortable situation having to deliver this news, but trust me, the family will break the silence, often to ask further questions. You know, this is your chance afterwards to offer your condolences once again, answer any questions that do come up, and let them know you're available for them, that you did what you could, but unfortunately it didn't work out. It's absolutely worthless to keep talking after you've said your family member has died, because nothing is really going to register at that point. So, you know, once again, once you deliver the news, just be quiet. Nothing you're going to say is of any use at that point until the family is over their initial shock and ready to start asking some questions. Leaving the room can be a little bit awkward, of course, but, you know, just something I like to say is, you know, I'm going to have to excuse myself. But if you have any questions, please do not hesitate. Myself and the rest of the medical team are here for you and your family, and that's just something that I've used myself.
Yeah, and definitely be as available as you can to that family. Some requests from them may be weird. I mean, some families will want their patient covered up by a sheet. I had a family member once ask me if I could just make her some tea and sit with her on the couch, and of course I did that. But be available to them for whatever they need, provided you have, obviously, the time and the resources to do that.
And then lastly, just the most common errors, number one is talking too much. This should absolutely be brief. To reiterate, once again, 30 to 60 seconds after you start talking, deliver the news. Next, you don't want to over-explain what happened, use medical jargon that the family might not understand. Keep it very simple. And then lastly, don't be so impatient to leave. It feels a lot longer than it actually is while you're sitting there in the situation when everyone's grieving around you. But trust me, you're not going to be in there quite as long as you feel you are. So try not to be too impatient to get out of there.
Good, and that concludes the bulk of our presentation. Just some conclusions about what we've talked about. The BLS TOR that we've introduced and the combined TOR are there for both the paramedics and the patient's safety and best interest. Patients who fit these criteria have an incredibly small chance at meaningful survival, which is what Samir has presented in the extensive research that he showed. And that 100% sort of is a red flag to me in so many of the research that he showed.
And this is not, once again, this is not the same as a no service. You are not denying these people some heroic therapy that may save them. The survival rates are absolutely dismal for people meeting these criteria.
And keep in mind, too, this is evidence-based medicine, and there's a reason that this has been introduced province-wide. If you're ever unsure or in an unusual circumstance, you always have the ability to patch to a base hospital physician to ask for advice. So definitely keep that in your back pocket.
And sorry, I just have one question that I've been forwarded. I think accidentally just earlier while I was talking about the trauma TOR, I said it had patients had to be greater than 30 minutes away from a trauma center to use. Sorry, that was a mistake. Patients need to be greater than 30 minutes from any hospital, not just a trauma center. Yeah. I apologize for that.
Keep in mind that your C-test ones always go to the closest hospital. And again, just concluding here, take the time to speak with the family members as we discussed. It's going to be the worst day of their lives, presumably. So take the time and the effort to do what you can to console them.
And here are our references just at the end. Please feel free to go through each of those. At this point, we'll open it up to the group. We have about 10 minutes or so, so please ask any questions that have come up. Hopefully we didn't confuse you guys even more.
We'll also introduce Dave Usage, the training coordinator. Dave, if you have anyone there that's willing to ask a question live, we're more than happy to take it.
Thanks, Steph. And first of all, thanks to you and Samir for a great presentation. And I will say that my fingers are burning up. There's been so many chat questions and discussions going on in the background. So hopefully, if you do want to ask a question, you do it live on your webinar. You'll see a spot where you can actually click on that hand, and it kind of raises a little signal here, and it tells me that you want to ask a question. And if you have a microphone on your computer, I'll let you know that your mic is open. You can ask your question directly. So if anybody's got a question, just click on that hand, and we'll see what we've got. Nope, looks like a pretty quiet bunch. So I've got no hands coming up for a live question. And there's only one outstanding. Just give me 1 second here. Cell phone failure. All right, so here's a good question. This is just typed in. So if you have a cell phone failure, do you have to try via radio telephone if the ambulance is not close to scene, or use a resident's phone? So if we're trying to make that patch at the mandatory patch port and our cell phone doesn't work, what are other options here?
So at this point, we're going to have to use some sort of common sense and some sort of best clinical judgment. Let's say you've hit your third analysis and you've attempted to call the base hospital physician and for whatever reason cannot get through, and you try again and you still can't get through. Another point to touch on here is that if you're doing your 2 minutes of CPR and that it's time for that fourth analysis to come up, you still need to go ahead and push that button or analyze the rhythm. At this point, you do not have direction from a base hospital physician to cease resuscitation efforts, so do continue your call. If for whatever reason you cannot get through, use your best judgment as to when you stop attempts at patching and transport, and there's nothing wrong with that. Hopefully that answers that question.
Cool. And one more, and I know we've touched on this in some of the courses because this was one that cropped up. But if EMS arrives, fire's already there, fire department has already done 3 no shocks on their defib, how do the paramedics react? So I'll jump in on this one if you don't mind. That was a question because we know we do have a lot of fire departments with AEDs now. Unfortunately, a lot of their machines don't have a ECG display screen. So while we may be getting the message that they're in a non-shockable rhythm, we don't really know if that's assisted or PA. Now, at the end of the day, doesn't change the directive. However, it was agreed that in this situation, the paramedics should at least put on their defib and analyze once and then make the patch and let the base hospital physician know that some of the no shocks have been by fire, that you followed up, that you also have a no shock, and at least that way you would also be able to tell the physician whether it was a systole or PA in that case.
Good, thanks for taking that, Dave.
And I'm just looking for any other questions. I don't see any hands coming up for a live question. I think we've covered off all the typed questions that were there. So Stephanie and Samir, I'll let you bring it to a close then.
Okay, thanks, Dave. Just before we do bring it to a close, for those medics who wanted CE credit for this webinar, there's no need to actually go into the registry and request that CE credit. We will actually go in and do that for you. So no need to go into the registry. Michelle Fraser will actually go ahead and do that for us. So don't bother again. Once again, big thank you to Dr. Samir Mao for joining me on this webinar, and thanks for attending.
Yeah, thanks everyone. It was a pleasure. I hope you guys found this informative and useful, and please feel free to stop us at any point, ask us questions if you see us walking around the Emerge. We're more than happy to talk to you guys further about this. Thanks again.
Thanks guys, have a great day.
Thanks, everyone.